Hello, I'm Dale Berry. I'm a certified prosthetist and owner of Prosthetic Xpert Consultation. Today I'm here to speak with you about proving medical necessity. Now you would think for prosthetics, proving medical necessity would be pretty straightforward. A patient comes in, they've undergone an amputation, and they literally don't have a leg to stand on. So building them a prosthesis, you meet with them, you evaluate them, you design a prosthesis, you fit them, patient's happy, everyone's happy, medical necessity's obviously been established. But it's not quite as simple as that. Because what type of prosthesis was necessary for the patient? Now, identifying that it's medically necessary for the patient to have a prosthesis is pretty straightforward. But what type of prosthesis? What kind of socket? What kind of suspension? What kind of foot is truly medically necessary for this patient to accomplish their activities of daily living? So the first thing we have to do is, well, what does medical necessity actually mean? Well, it's two words. The first word is medical, a curative remedy, therapeutic treatment, clinical care management. And then the second word, necessity, pretty straightforward. Necessity, it's indispensable, it's essential, it's required. Medical necessity means the individual needs this device. The Medicare definition is very specific in the regulatory standards. It's a healthcare service or supply that are needed to diagnose, treat an illness or condition or a disease and its symptoms, and that meet accepted standards of medicine. This definition is adopted by most insurance companies that provide payment for orthotics and prosthetics. Notice it meets standards of medicine or standards of care. Well, standards of medicine and care are based upon clinical, scientific, medical, and empirical evidence. Professional opinion is important. Judgment, experience, observation. Basically, professional opinion helps form the standards of care. But medical necessity is based upon standards of care. So medical necessity, to truly be medically necessary, is the outcome cannot be accomplished without the service, components, or the device that's being proposed. So today we want to talk about how do you prove medical necessity for a prosthesis? Well, one of the things that we have to first understand is within the CMS regulatory guidelines that with regard to medical necessity documentation criteria, it is the treating physician's records, not the prosthetist, that are used to justify payment. Now, there's also language in the Social Security Act that says for purposes of determining medical necessity, documentation created by the orthotist or prosthetist shall be considered part of the medical record to support documentation created by eligible professionals, and that being the referring physician. So to create and prove medical necessity, the documentation is a combination of the referring physician, who basically will identify the necessity for the prosthesis or for a prosthesis. And then the prosthetic provider can provide the medical necessity documentation to identify the medical necessity of the specific design of the prosthetic device. Now, I've seen some instances where a prosthetist will help the physician and will write a clinical note and give it to the physician to put on the physician's letterhead. And when I review prior authorization claims for national insurance companies, commercial carriers, and work comp, I'll see some of these evaluations where the physician has signed it and it says, I'm the treating physician, I agree with the prosthetist evaluation. Understand with most insurance companies, and especially with Medicare, writing a note, giving it to the physician, and having the physician sign it does not meet compliance standards. In fact, the Medicare Supplier Manual, Chapter 3, Section 4, page 7, is very clear. It says supplier-produced records, even if signed by the treating practitioner, and attestation letters are deemed not part of the medical record for payment purposes. So it's important that the physician do their part on their own. And with regard to the regulatory standards for physicians, which is adopted by the majority of insurance companies, you can basically go online and you can search for Dear Physician Letter Medicare. And it's a very clear outline of what the expectations are for the physician to document in the medical record, to do the physician's part. So he or she, the referring physician, can write their documentation of why this person needs a prosthesis. Now for us as clinicians, it is now our job to prove and establish medical necessity of why they need that specific foot or that specific component. There's many different types of devices out there. Why is this device more medically necessary than this device? So we have to basically have a process and a procedure to establish medical necessity for these devices. We also want to make sure that we use very specific language when we are describing these devices. So it's important that we make statements about products that we can back them up with peer-reviewed studies, with scientific claims. So when we prove medical necessity, we want to establish why is this device the appropriate device for this patient, as opposed to waxing poetically about all the marketing claims and different aspects of a device. We want to know why this device is for this patient. An important reason that we need to do this prove medical necessity is because starting September 1st, Medicare is now doing prior authorizations for major components and in 4 specific states. And on December 1st, 2020, these prior authorization will be required for all states and territories. So by December 1st, 2020, the vertical shock pylon, microprocessor foot, all microprocessor knees, and the carbon graphite 5980 foot will require prior authorization through Medicare. And with all of our payers, we need to set a standard, a process and a procedure to clearly show and clearly document that we have documentation for the payers so we can prove why these devices are medically necessary. That's what I'm here to talk to you today, is to take a look at a process and procedure of how we can establish, document, and prove medical necessity to get the most appropriate device on the patient so they can accomplish their activities of daily living. Our goal is very clear. Provide clinical documentation to confirm that this specific device is necessary for this patient and meets clinical standards of care. To determine if a prosthetic device is the most appropriate or medically necessary device for that patient, that can only be determined if we have the information about the patient's status. Basic information to identify the patient's capabilities, their functional needs. We need to know the basic information about their age, their weight, date of amputation, and if they have a current prosthesis and are replacing it, we want to know the age of their current prosthesis. Also, we need to know the side and level of amputation. After reviewing numerous files for insurance companies, commercial and workers' compensation, one of the most common things left out is the level of amputation. We know specifically that it's a transfemoral amputation, but we don't know the length. Is it short or is it long? These are important factors with regard to determining what would be the most appropriate device for that individual. A short residual limb for a transfemoral would potentially have a flexion contracture, or the patient would have a weaker hip and perhaps need more stability than somebody that had a long residual limb that had a longer lever arm. And for upper extremity, it's equally as important. With regard to upper extremity, especially for myoelectric devices, you have to concern ourselves with what kind of components can be used and have to be concerned with the length of the residual limb. So identifying the specific length of the residual limb is very, very important. Now with lower extremity amputations, it's also important, of course, to establish the functional level. Functional level determines what type of components will be appropriate for that patient. Now this is something we've been doing for many years, and it's something that just simply needs to be documented. What is the patient's functional level and what activities is the patient doing to justify or validate that functional level? But even with upper extremity, it's recommended to also identify the activities that the upper extremity prosthetic wearer is doing. Are they doing domestic activities where they're just around the house watching television, doing cooking, doing basic chores? Or are they full community activities where they're out and about, so they'll be basically using bimanual tasks for doing many different types of activities out in public? Or perhaps heavy-duty activities like construction work. Knowing what the patient's functional needs are and functional requirements are important to establish what are the appropriate prosthetic components for that individual. And especially for upper extremity. With upper extremity, no one prosthetic device can necessarily provide the function for an individual. So the individual might have certain criteria where a body powered would be better for certain functions and a myoelectric better for others. And then of course you have passive cosmetic devices. So it's important to understand exactly what the patient's daily activities are, what their functional capabilities are, and their functional needs are, to be able to determine what device is going to be functionally appropriate and medically necessary, or what combination of devices We can only know this if we have a clear idea of exactly what the patient's functional status is. So our goal here is to provide a clear picture of the patient's condition, their functional status, and their activity of daily living requirements so that we can determine what prosthetic components will best accommodate those particular functions. For a new prosthetic wearer, someone that doesn't have a prosthesis, establishing a reason for them getting a prosthesis is fairly self-explanatory. However, if the patient already has a prosthesis, one of the things that must be established is why is the current one being replaced? What is the medically necessary reason for replacing the prosthesis? Now, there's typically two reasons to replace a prosthesis. Number one, change in patient condition. Change in their functional level, their residual limb has changed, they've had atrophy, or their activities of daily living have changed, or their employment has changed. Something's changed in the patient's life so that the prosthesis that they have no longer meets their needs. The second reason to support a new prosthesis or replacing a prosthesis is change in the prosthetic condition. And that's basically irreparable damage. So if the prosthetic device is damaged and it's not repairable, this needs to be clearly documented. What you need to do is list the major components by name. What kind of make of knee or foot and make and model. Document the specific damage. And for microprocessor knees, obtain a quote from the manufacturer showing how much it's going to cost to repair that device. One thing that needs to also be acknowledged about prosthetic devices is that according to Code of Federal Regulations, Title 42, a prosthesis that's been in continuous use has a reasonable useful life, or an RUL, of no less than 5 years. So a prosthetic device, and this is adopted by most major carriers, the expectation that a prosthetic device will last 5 years. So if it's less than 5 years and it needs to be replaced, it's very important to document why. What changed? And it's either going to be a change in the patient's condition or the device is irreparably damaged. A common reason that we sometimes see people apply for a prior authorization to replace a prosthesis is because it's out of warranty or wear and tear. Neither one of these reasons is foundation to replace a prosthesis. I often say in jest, if things need to be replaced because of wear or tear, at 60 years old, my wife would have replaced me a long time ago. I've got a lot of wear and tear. But also out of warranty. Take a look around your house. Look at your fridge, your stove, your microwave. Is it under warranty? Most homes, they're not. They're out of warranty, but do you replace them? You don't. Just because something's out of warranty doesn't mean it needs to be replaced. Warranty has nothing to do with replacement. All warranty affects is, does repair going to be paid for by the manufacturer or not? So out of warranty is irrelevant. Wear and tear doesn't really say anything. What we're looking for is to establish the irreparable damage or identify the change in the patient's condition. The goal to replace a prosthesis is very clear. Just clearly explain why the patient requires a new prosthesis and explain why the current prosthesis is not meeting the patient's current needs. An important piece of information to include with any prior authorization package to verify and validate and prove medical necessity is to have a very detailed listing of the major components that are going to be included in the prosthesis. Often a prior authorization package will say it's going to be a microprocessor knee or an energy storing foot or a generalized description. But what's very, very helpful to know exactly what device is being suggested. To identify the specific manufacturer, make, and model of the device that's being prescribed to this patient. The reason for this, it's the only way that the payer can validate and verify that the correct codes align with the device that's being requested. This also helps the payer to be able to identify and benchmark any warranties that might be attached. By knowing the make, model, and manufacturer, we can easily cross-reference that to have an idea of what the expectation of the warranty on each one of those components are. So the goal is very specific, to have a complete package to prove medical necessity and validate for prior authorization is to identify any specific major components being requested with the manufacturer, make, and model. We'll be right back after this very important public service announcement.
My pandemic has a first name, it's COVID. My pandemic has a second name, the number is 19. And if you stay 6 feet away and wear a face mask every day, then someday soon COVID-19 will finally go the hell away.
Arguably one of the most important components of proving medical necessity is to validate the recommendations. It's to answer the simple question, is why does this patient require this component to achieve activities of daily living to be able to be fully functional with limb loss? It's very, very important to understand that many times when the request is asked, why does a patient need a particular component? The answer is a description of the component, saying, well, this foot does this or this knee does this, which is nice to know what the knee or the foot or the component or the prosthetic device is capable of from a design standpoint, but it actually doesn't answer the question. Is why does this patient require this component? Describing the component doesn't answer that question. Let's take the example of this, we'll call it the magic foot. The new motion, action, gait, intuitive controlled foot. Now this isn't a real prosthetic design, it's just something that I made up digitally with an image. But what's important to understand is notice all the features of this foot: real-time control, hydraulic control, it's got advanced pivot mechanism with a dual pivot hinge. All of these descriptors, all of these features have been gleaned from existing marketing brochures and websites of existing devices. And that's the challenge we're often faced with when a prior authorization comes in to validate medical necessity. They're saying, well, why does this patient need this foot? And they said, well, it's got an intuitive multi-blade, it's got 30 degrees of ankle motion. It doesn't answer the question. The question is, why does this patient need this foot? Why is this magic foot the most appropriate and medically necessary design for this patient? So it's a matter of marrying the functions of the prosthetic device to the needs of the patient. For upper extremity, it is also imperative to do the same thing, to identify why this device is important for this patient. Here I've got a fictitious hand. This isn't a real prosthetic device, but it's one that I've created for this particular example. And we'll call this is the hold hand. It's the hand of limitless dexterity, and that has 24 grips and a breakaway thumb and independent digital control. These are all wonderful features. But does the patient need these features? So if the hand has 24 grip patterns, it's imperative to show, why does this patient need 24 grip patterns? What specifically is this patient doing? Now, it's fair to say the patient might not need all 24 grip patterns, but basically be able to identify specifically, what is this patient doing? What are this patient's needs that they need to have multiple grip patterns to accomplish their day-to-day activities? So that's the important thing about medical necessity. It's verifying and validating why it's medically necessary. What specific need does the patient have that this device is going to provide? It's a matter of connecting the dots. The first dot is the patient's needs and their capabilities. The second dot is the component, features, and functions. And our job to be able to prove medical necessity, to establish a foundation to secure a prior authorization, is to connect these two dots. We need to clearly show why this component fills a need for the patient. We want to be able to identify what patient functions can be completely filled by the features of the component. So our goal is very specific. The key to establishing and proving medical necessity is validating the need of that device to justify what functions and activities the patient does that necessitates the features of each major component. The final administrative task for putting together a prior authorization package to validate and prove medical necessity is to enumerate the coding and the pricing. This is to simply confirm that the codes are aligned and compliant with the device that's being provided. I want to take a moment to talk about 99 codes here with regard to unbundling of 99 codes. A common practice within the prosthetic industry, specifically more so in upper extremity, is to unbundle a device and break it down and describe every single feature of the device, specifically with 99 codes. So if we're looking at our mystical hand here, the hand of limitless dexterity, with this fictitious hand, we could apply many 99 codes to it. And in this particular example, each one of these 99 codes have been gleaned from coding suggestions and recommendations from manufacturers and practitioners on existing myoelectric devices today. So what's being done is every single feature of the device is being split out and billed separately, which actually creates a challenge. And that challenge is you are now in a position to establish medical necessity for every single one of those line items. It reduces confusion and makes it much simpler if you do a single line item component charge. If you're going to apply a 99 or a group of 99 codes to a single component, to one component, then it makes logical sense to have a single L code. You as the clinician, when you purchased this device from the manufacturer, it was one line item. It was one line item for this hold hand. So when you paid the manufacturer one price for that line item, because you're using a 99 code, it's logical to bill one price. That way, when you're taking a look at why the patient needs this device, it's because the combination of functions of this device are meeting the patient's needs. By breaking them out and billing for them separately, you are implying that that one feature or function can be taken out. And it can't be taken out because it's part and parcel, integrated part of that device. So our goal when we are enumerating the price is to clearly list the coding and pricing so it fully aligns and complies with the medically necessary components that are being recommended. So with this review, we've identified the 5 key factors, the 5 key pieces of information that must be in a prior authorization package to prove and validate medical necessity. But what's also important is to present that information in a well-organized document so that when it's being reviewed by commercial insurance or by workers' compensation or by Medicare, that the reviewer can easily glean the information from the package. So with that consideration in mind, on my website at www.pxcrx.com, if you go to downloads, I have created some prior authorization documentation to assist you to collect the information to prove medical necessity so it can be presented to an insurance company in a very coherent and an easy manner. Now, with these documents, you'll know when you download them that they are open access, so you can use them exactly like they are. In fact, there's a spot in the upper right-hand corner where you can put your company logo there, or if you choose to change it around and take bits out or change or add things, you're more than welcome to do it. These documents, as I said, they're used for permission and they're open access documents. I am releasing them for use to anyone who chooses to use them. So these documents provide a very simple process for you to capture the information, but more importantly, so that when a case manager or an insurance company is reviewing it, they can look at this information and quickly grasp and capture the information that's important. On the top of page 1, patient status. It identifies the patient name, their amputation level, the length. You know, if you're doing for lower extremity, there's K level evaluations. There's a place for a PAVIT score or an AMPRO score or a plus M score, whichever system you're using. Or for the K level, you can put in some documentation, some information of why that patient is at that K level. And you can also put the age of the current prosthesis, and if they don't have a prosthesis, it's their first time wearing a prosthetic device, then you just click not applicable. And then you would skip Section 2, which is relevant to replacement justification. Now there's actually 2 forms. There's one for upper extremity and one for lower extremity. Upper extremity has a little bit different information to compile, which is relevant to upper extremity. And also, On the upper extremity one, there is an image of a right and a left hand. So if you have a partial hand amputation, you can simply draw lines through so you have a clear idea and a clear picture of exactly where the amputation lies on each one of the digits of the individual's hands if they happen to be a partial hand amputation. For the replacement justification, again, very straightforward, very simple. You can identify the patient needs a replacement socket, replacement components, or a whole new prosthesis. And what's the reason? Functional change, residual limb change, change in their employment or their ADLs or other. And then there's an area to write in some documentation to clearly identify what the specifics are. Also, regarding the foot and the knee and the socket, you can identify the status. Is it acceptable as is? Does it need adjustments? Does it need to have a change, basically become irreparable damage? So you can basically check the box to identify exactly what's wrong with the device, and then you can write in some documentation. So you can put the foot, you can say, this is the manufacturer, this is the model, and the foot needs to be replaced with irreparable damage because the carbon graphite keel is broken and split. So you can provide simple information. Obviously, for the upper extremity form, it's got a place for the terminal device and for the hand and the elbow, if applicable. For the overview of recommended components, pretty simple, pretty straightforward. For the lower extremity, place for the foot, who's the manufacturer, what's the model number, if the knee, if applicable. And for upper extremity, obviously, it's for the elbow and for the hand and the wrist unit. So the obviously major components is what you want to identify. And then the most important part is validate recommendations. And here is where you connect the dots. So for the lower extremity, the foot, the knee, any other potential component, the major component you're being using. But for the foot, you can say exactly what the patient's activity is, what their need is, what their ADL is that they have a particular need for. They may have a job where they're walking all day long on hard surfaces, or they're a carpenter, they're walking on uneven surfaces all day long. And then beside that, you look at the features and function, and you can identify what the feature and function of that foot is to marry to the need of the patient. So you're connecting the dots. This is what the patient's doing, this is the function or feature of the foot, and this is why it is medically necessary to accommodate that patient. And then for the upper extremity, of course, it's going to have it for the hand and for the terminal device or for the elbow if it's applicable. And then for the enumerate coding and pricing, that would be a separate page, obviously, where you would include all of your coding and all of your pricing. And now you've got a complete package. 3 pages, 4 pages. You've got page 1 and 2 of the Prove Medical Necessity, plus your coding and pricing page. And now, when it goes to a prior authorization reviewer, everything they need is in one simple package, put together with a prescription from the physician, with a detailed written order, and then you've got a package that's put together. So this is the step-by-step process of proving medical necessity. You identify the patient's status. If they already have a prosthesis, you have your replacement justification, a simple overview of the components. Validate the recommendations of why this specific device is appropriate for this patient's specific day-to-day activities, and then enumerate your coding. And that is how you prove medical necessity to secure your prior authorization. Remember, these 2 documents to provide you with assistance on proving medical necessity are available at pxcrx.com in the download section. They're easily downloadable and they are open access, so you can use them any way you so choose. I'd like to take this opportunity to genuinely thank AOPA for the opportunity of presenting this information and sharing it with my associates. And I would like to genuinely wish all of my colleagues well during these unique and challenging times. And thank each and every one of you for your continuous and tireless efforts to deliver essential services to prosthetic and orthotic wearers across our great nation. Thank you for all you do. Be well, stay safe.